morning. This is Community Chats. I'm Sandra Arevalo. I'm the Director of Community Health. And today we're talking about strokes and who can be the best expert to talk to us about a stroke than our stroke coordinator here in the hospital in Montefiore Nyack, Shelby Barrios. And Shelby, I might be cutting short on everything that you do because I know that stroke is not the only thing that you do in the hospital. I definitely see you like going everywhere. So why don't we start and you tell us a little bit about what is it that you do at the hospital and why are you so involved with the stroke?
Sure. So good morning. I am Shelby Barrios. I am the Stroke and Sepsis Outcomes Manager here at Montefiore Nyack Hospital. So as Sandra mentioned, I respond to all of our code strokes and kind of align care for everybody with the standard of care at this point for stroke and sepsis. So we'd also like to introduce Dr. Andrew Arian of Neurology. He directs our stroke program.
Hi, everybody. How are you? As Shelby said, I work with her. I'm the stroke director, but behind the scenes, we're all a team, and we are here to discuss about preventing stroke.
Thank you. That's right. So we are going to use the American Stroke Association PowerPoint, and everyone can see my screen, right? Yeah?
Yes.
Okay. So we're going to use their PowerPoint, but we're not only going to talk about preventing stroke, we're also going to discuss recognizing stroke, when to get help, when to go to the hospital, okay? So let's get started. Where is my, sorry, where am I? Here we go. Oh. It's not moving forward. Give me 1 second. Here we are. Okay. So, a little bit about the brain before we dive into stroke. It is the central organ of the human nervous system, right? Without your brain, your body cannot function. So it controls motor and sensory functions throughout the entirety of your body. It receives, it interprets all of the information from all of your senses and directs them, has your body respond to them. So it's responsible for thinking, remembering, understanding, planning, problem solving. So all of the things that we do in our daily life, our brain is responsible for getting those messages where they need to go. So although it is pretty small, it is the most complex organ of the body. That being said, it is made up of billions and billions of neurons or brain cells that communicate with one another in order to get those messages where they need to go. Okay. It does reach its maximum size by the time you're 18 years old, and it does something very interesting about the brain is that it is constantly changing and adapting to new challenges, new experiences, new events. Okay, so what is a stroke? A stroke is a disease or an event. It affects the arteries, the vasculature in your brain, right? So a stroke happens when there is an occlusion, a clot, a disruption in the blood flow, the oxygen getting to any portion of the brain, whether it's caused by an occlusion, whether it's caused by a rupture, a burst. We'll discuss that going forward as well. Whatever area of the brain that blood flow, that oxygen would be going to, it's disrupted. So brain cells on the receiving end of that vasculature then die, and that's what causes the symptoms of a stroke. Okay, so any brain injury from stroke can affect any, depending on the area of the brain affected, will then affect the disability or the outcome, right? So the ability to move, think, behave in a certain way, and we'll talk further about these symptoms, but it really just depends on the area of the brain that vasculature is communicating with. So a stroke, as I hope all of you know, is a true medical emergency. And if and when we're suspecting any stroke or stroke-like symptoms, we are getting immediate treatment in order to minimize these long-term effects of stroke and potentially death. So some facts about stroke. A stroke is a brain attack. I want you to think about a stroke the same way that we think about a heart attack, okay? It is the exact same mechanism, or it's the brain being affected after the heart. So it is that severe, it is that important to recognize these symptoms and get the help that we need. So although stroke is more common in adults over the age of 55, it can happen to anybody at any stage of their life. It is the #1 leading cause of adult disability. Some people who have stroke will make a full recovery, but more than 2/3 of survivors will have some type of disability. Approximately every 40 seconds, someone in the United States has a stroke, and approximately 1.9 to 2 million brain cells die within every minute that the stroke is occurring. So it's a lot of brain cells very quickly, and that's why it is so important to get help very quickly, and we'll discuss that. So how common is it? A stroke has a large impact on our society. There are more than 9 million stroke survivors in the United States. That's a lot of people. Every year, about 800,000 people in the United States are having strokes. About 185,000 of those people have already had a stroke prior to that. So this would be like a secondary stroke for them. It is the 5th leading cause of death in the United States, the 3rd leading cause of death in women. 55,000 more women than men have a stroke each year. And Black people are twice as likely as white people to have a first-time stroke. Treatment reduces the effects of the stroke if administered soon after the onset of symptoms. And that is really why we do this community education, right? We are going to modify the risks for having a stroke, an event, a neurological event. However, it is so important that if and when these events occur, that we are getting help in the most timely manner possible, okay? So we're going to talk about some lifestyle changes coming up that we can make to prevent strokes. About 80% of strokes may be prevented with those lifestyle changes. So the first type of stroke that I want to discuss is an ischemic stroke. And I did mention a little bit about this earlier, but it is the most common type of stroke. It accounts for about 87%, if not more, of strokes. An ischemic stroke occurs when a clot blocks a vessel. So it may be it might be plaque causing the occlusion. It may be a blood clot causing the occlusion. But despite the mechanism, it is an occlusion, okay? So the artery becomes narrowed or completely clogged or occluded, cutting off that blood flow and that oxygen delivery to these brain cells. And that's what causes these symptoms. This is what people, when they think of a stroke, this is what it's like, right? There is, however, another type of stroke, a hemorrhagic stroke. For those of you that are unaware, a hemorrhage is blood, right? So this happens when a blood vessel that would be communicating to the brain bursts or ruptures. This type of stroke affects large arteries in the brain. It could be small vessels, any vessel, deep within the vein, right? So the rupture keeps the surrounding areas of the brain from essentially getting the oxygen that they need and having these messages delivered to those areas of the brain. They are less common than ischemic strokes or strokes caused by occlusion. However, they are associated with a higher risk of mortality. Okay, and then a transient ischemic attack. A lot of people that come in from the community that have had these events this is, I think, what a lot of people call these mini strokes. It is essentially a transient or a temporary ischemic stroke. So it is very much the same signs and symptoms of an ischemic event. However, they resolve on their own without any intervention. Why? While they don't cause permanent damage, it is a warning sign and very often precedes a true ischemic event, a true ischemic stroke. So this is an opportune moment for us when somebody comes in with these transient symptoms to then intervene so that they don't progress to a true ischemic event in the future. So warning signs, okay? These are kind of the textbook most common signs of stroke. So the face, everybody knows this, like that facial droop, right? It may not always be just the facial droop, the smile. A lot of times it can be the eyebrow, but it is one side of the face, okay? So kind of asking someone to smile, is it uneven? Raising their eyebrows, again, one side of that face. We like to use the acronym FAST just so you guys can remember. But it's face, arm, speech, and time. Arm, it doesn't have to just be the arm, but the arm or the leg, sudden onset weakness, numbness, paralysis of one side of that body. Is there a drift where there wasn't before? The important thing to remember here is that it is a sudden change. You were fine and then you were not. You went to bed last night at your baseline, you're normal, and now you woke up and you're not. Sudden change, okay? Speech, whether it's understood speech, you're not understanding what somebody's saying to you, or it's your speech, you're speaking, your ability to swallow, any, again, sudden change in any of those things, you need to come to the emergency room right away, right? And then time. Time is actually the most important component of all of this. You have to respond timely because there is a very limited amount of time we are able to intervene in order to help you. Okay, so if you observe any of the signs, symptoms of stroke, please call 911 immediately. Do not drive yourself here. Have the ambulance deliver you to our emergency department. That way we can get you help in a timely fashion. That being said, the reason time is so important, like I said, we do have a limited time to intervene. We only have up until 4.5 hours at this point to give you thrombolytic medications, and we'll talk a little bit more about that going forward. But these clot busting medications, we only have about a 4.5 for the most opportune patient, the most high, the most perfect candidate. We only have up until 4.5 hours at this point in order to intervene with these medications to hopefully abort the stroke and save some of these neurons. That being said, if you're outside of that window, there really is only up until about a 24-hour time period to go in and get a clot if there is one. So getting here as soon as possible is the most important thing I want you to take from this. Other signs, symptoms of stroke, maybe numbness. Again, typically one side of the body. Confusion, trouble speaking or understanding speech. We have patients that come in that they didn't realize the speech when they're speaking is not being understood. They went to work and a coworker is saying to them, I'm not understanding what you're saying. What are you talking about? And that's kind of the first time that they notice. So it is interesting. Trouble seeing. Vision, it's not always trouble seeing. It may just be a change in your vision, any change, sudden change in your vision, whether it's a part of your visual field is missing now. It may be blurriness, sudden change. Trouble walking, whether it's dizziness, loss of balance is more often what we're seeing, or differences, a sudden change in your coordination, as well as severe headache with no known cause. Okay. So acting quickly. If you experience one or more of any of these symptoms, please call 911. Again, don't drive yourself here. Please call an ambulance and have them bring you to your closest emergency department. Medical intervention very likely may reduce the effects of the stroke. Time is the most important thing. as treatment, like I mentioned earlier, really needs to be administered soon after the onset of strokes to really optimize the outcome. So it says here, stroke strike quickly. You should too. And that's probably the best way to say it. But why you must learn to recognize stroke symptoms fast. It's saving the lives. It's easy to remember. So FAST, that acronym is so easy to remember, and that's why we use it. So face, arm, speech. Okay. So the effects of stroke, these symptoms of stroke, they really do depend on factors, most influenced by the area of the brain that the occlusion or the bleed is taking place in, the size of the stroke, the size of the clot, the size of the bleed, and then the functions that are damaged kind of by that area of control in the brain. How can a stroke affect you? Like I mentioned, the most common symptoms, the weakness, the loss of sensation on, so if it's your left side of your brain that's being affected by the occlusion or the blood, you're most often seeing symptoms on the opposite side of the body. So whatever side the brain is affecting, that the stroke is affecting, you're going to see symptoms on the opposite side of the body, typically. So if it's affecting your left side of the brain, you're going to have a right-sided weakness. You're going to have speech and language difficulties, inability to read, write, absorb new information, slow, cautious behavior. Or any change in behavior, really. Reduced ability to problem solve, reason, analyze, and then memory loss. Whereas when the right hemisphere, the right side of your brain is affected, you'll have weakness or loss of sensation on the left side of your body. Perception, your depth of perception, directions, you may have trouble with this, vision problems, a change in behavior, like I mentioned before, it can really be either side. Excuse me. Lack of ability to recognize emotions and memory loss. Okay, so risk factors that cannot be controlled. These are things that we cannot change. So our age. Again, these strokes can happen at any point in your life, but they do, the risk of stroke increases after the age of 55. Your family history, unfortunately, we can't do much about that. Race and ethnicity, Black people do tend to have a higher prevalence of stroke, a higher death rate from stroke than any other racial group. Gender, women have a lower risk than men before menopause, but they have more women die than men of stroke. Prior stroke or TIA predisposes obviously us to having a true stroke. If you've had a stroke, you are at a stroke in the past. You're at a higher risk of having another. So almost 1 in 4 people that have had a stroke in the past will have a recurrent stroke within 5 years. So medical risk factors. Dr. Arian, do you want to discuss these or do you want me to keep going?
It's up to you. You can keep going. I can add in if needed.
Okay. So medical risk factors, having high blood pressure. So for every stroke, but hemorrhages in particular, a prolonged high blood pressure, untreated untreated hypertension is one of the highest risk factors. So we should be having routine blood pressure checks. A measurement of 120 over 80 and above is considered high. So we really want to keep it below 120 over 80. Know what your baseline blood pressure looks like. Work with your primary care provider to manage that blood pressure. And like I said, everyone's baseline is a little bit different. So just knowing what your normal is and keeping you within a safe range there. Diabetes, having diabetes, it more than doubles your risk of stroke. High blood glucose, so untreated diabetes, increases plaque buildup and damages the arteries. And that's why the risk is so much more significant in patients with diabetes. High cholesterol, so that buildup of fatty deposits in the cells is causing this plaque buildup and occlusion of these arteries, right? Circulation issues this causes blockages in the arteries, the vessels that carry blood to your heart and to your brain. So you are more likely to occlude. And then atrial fibrillation. So, and arrhythmia of the heart. It does increase stroke by 5 times. So lifestyle risk factors. These are things we can control, right? So these are where I want you to focus your efforts and where we can really do some good work in decreasing our likelihood of stroke. So tobacco use, vaping. Current smokers have 2 to 4 times an increased risk of stroke as compared to non-smokers or those that have quit smoking for more than 10 years. Reducing alcohol use. Heavy drinking increases your risk for stroke. They do recommend no more than 2 drinks per day for men and no more than 1 drink per day for non-pregnant women. Maintaining a healthy weight. So obesity, of course, excessive weight can put a strain on your entire circulatory system, your heart, and then in turn increases the risk of stroke. So increased physical activity. Physical activity helps reduce our stroke risk. They do recommend at least 30 minutes, maybe just like a light walk a day, 30 minutes of movement. Try to get your 10,000 steps in for the day, and aim for at least 150 minutes of moderate to vigorous intensity physical activity per week. And then a healthy diet. So this one is huge for modifying risk, but it is proven to be one of the most difficult things to change. People don't want to change their diet, right? People don't want to modify what they're eating. People like what they like, but it really does have such a big impact on our outcomes here. So we want a lot of fresh fruits, veggies, a low cholesterol, heart healthy diet really is what we're going for. So lots of proteins, but lean meat, fish, beans, minimally processed foods, a limited salt intake. That sodium intake is big, okay? But I know that's a hard one for us. Limited intake of sugar and then avoiding fried foods. So a lot of the good stuff we have to really work on limiting our intake of, right? But it is so important. Diagnosing a stroke. So in the event that you had these symptoms of a stroke and you presented to the hospital, we would do a full and thorough workup. Okay, so what does that look like? A patient that comes to our emergency department, whether they are walking in through triage themselves or a family member has brought them here, or they've arrived through ambulance, we would then call a code stroke if you are displaying any of those symptoms and it's within the 24-hour window for intervention. We're calling a code stroke and everyone is responding immediately to the area that you are in. We are doing simultaneously a full head to toe and neurological assessment, seeing what we're a candidate for in the way of intervention. We're getting vitals. We are weighing you because this medication, if and when you do need it, it is weight-based. And then we're doing our CAT scan, our imaging, whatever we need right in that same area. So all of this it's a whirlwind, but it is all done for that reason of getting as much information as possible in a timely fashion. That way we can intervene and give you really the best outcome possible. So the lab work, like I mentioned, physical and neurological exams, asking about your medical history. Those of you that have a history of AFib, if you're on anticoagulation, these are all things that you really need to mention when and if you were to present with any of these symptoms, right? Because that really rules us in or out for candidacy, for intervention. Let's move forward. And like I said, we're going to at that time do a CAT scan, an MRI later on in your stay, but right in that moment we'll be doing a CAT scan to really see is there blood, is there occlusion of any kind, and what we're going to do about that. So Okay, so Life's Essential 8. So this is pretty much a checklist for lifelong good health, right? So better cardiovascular health, it lowers the risk of heart disease, stroke, and almost all major health issues. So eating better, aim for overall healthy eating patterns, including a variety of foods, whole foods, fruits, vegetables, like I mentioned, lean proteins, nuts, seeds, cooking in non-tropical oils, such as olive and canola, being more active. You should be getting 2.5 hours of moderate or 75 minutes of vigorous physical activity per week, and quitting tobacco. So things that seem simple but are hard, a hard ask for people that are partaking in any of these, right? So here we go. Healthy sleep. This one's hard, especially for those of us that have children in the household. As an adult, you need between 7-9 hours of sleep each night. Adequate sleep promotes healing. It improves brain function. It reduces the risk for chronic diseases, but it is a hard one to manage. Managing your weight, achieving and maintaining a healthy weight has so many benefits, right? And losing as little as 5 to 10 pounds can make a significant difference in the risk for stroke or heart disease. And then controlling our cholesterol. So high levels, there's a few different types of cholesterol in your blood. Your LDL on your blood work, when you see it, when the doctor sends you, or maybe on your MyChart, if you're reviewing, if you're unfamiliar, LDL in your lipid panel is what we call your bad cholesterol. This is the cholesterol that is leading to the heart disease, the stroke, the things that are having negative impact on your cardiovascular health, right? So large amounts of cholesterol in the blood essentially build up and cause these clots, these plaques, these occlusions that in turn lead to stroke. Managing your blood sugar, especially if you're diabetic, making sure that you are taking your insulin if prescribed to you. You are checking your blood sugar in the morning, before, after meals, following doctor's orders essentially, and sticking to the diet that's prescribed to you. Because really, I know it seems like these are small choices on the day-to-day, but over time, maintaining a high level blood sugar can damage your heart, your kidneys, eyes, nerves, and then in turn cause heart disease and stroke, right? So, and then managing your blood pressure. So again, ideally maintaining at a level less than 120/80 is optimal. Okay. So your doctor, again, your baseline may be a little bit different. So this is something that I always recommend discussing with your primary healthcare provider. But high blood pressure typically is defined as 130/80 or higher. But 120/80 or less is really then what's desirable. So even if you're at or about 120/80, making sure that we're kind of maintaining that or even decreasing it a little bit, right? High blood pressure, hypertension, whatever you want to call it, it is the leading cause of stroke, and it is the most significant controllable risk factor for stroke. So I want you to keep that in mind. Okay, so a few more tips for reduction of risk for stroke is taking your medications, like I mentioned, as directed. Reducing stress, that's a hard one, but it contributes to a lot of things, not only the stress itself, but stress kind of, especially in women, creates these behaviors such as like the physical, a lack of physical activity, overeating, the unhealthy diet, maybe even smoking. These are all mechanisms to reduce stress. Looking for other ways to do that. So exercising, getting out, going for a walk, journaling. These are all things that we can kind of do to modify our stress there. And then having regular and frequent medical checkups. So increasing, having regular medical checkups, it includes the assessment of your risk for stroke, pretty much with the lab work, our blood pressure monitoring, things like this. Okay, so I've had a lot of talking. now time for questions, discussion, any feedback.
A lot of good talking though, Shelby. That was
Okay, sorry.
very useful information. Thank you so much. So at
Of
this point,
course.
I would like to invite our attendees. If you have any questions, please, use the Q&A or use the chat and start sending your questions. While you send your questions, I have a few of my own.
Sure.
So, Shelby, at the beginning of your presentation, when you started talking about the statistics, you
Yes.
said that African Americans have a disproportionate prevalence of a stroke compared to whites. Do we know why?
So there's a few things, right? So not only this is for a lot of diseases. It's not even just stroke. I'm sure you've seen these for quite a few, but cardiovascular health in particular, Blacks unfortunately have a higher risk of events. It has a lot to do with not only the history, but the foods that are, I mean, this is the same reason that we see for a higher risk for Latinas and as well, right? So a lot of salty foods, a lot of carbohydrate rich diet. It's the things we eat culturally. Dr. Arian, do you know any other kind of contributing factors in particular, or why African Americans, Hispanics are at a higher risk in particular?
So you actually touched on it. So actually, the largest amount of strokes in the United States are along the Bible Belt. They also call it the stroke belt. It's the South. That Southern food diet, the heavy fried, the heavy salt, even though it tastes amazing, because that's where I did my residency, you had a large stroke base. And I had seen patients younger than 18 years old. And it was just diet. They were very obese. Their cholesterol was through the roof. Hypertension, the hypertension, diabetes, cholesterol. Diet plays a part, and you got to remember wear and tear as you're getting older. Yeah, your body can accommodate, but over time it stops being able to accommodate. Then add in other risk factors: smoking, alcohol. Smoking makes the blood flow to the brain actually throughout not as smooth. So that's a problem. Too much of it and it starts to clog. And then drinking affects your heart. Too much alcohol. I mean, we just had a patient not even a month ago. He was patient was in 30s, between 30 and 40 years old. And the problem was his cholesterol was fine, everything was fine except alcohol. He was drinking so much alcohol that his heart pumping was only, I think, it was 15%, 15% of normal. And it wasn't pumping enough blood. He had a stroke, massive stroke. So those are the big things: diet, smoke, drink. And it's also a social. I can't speak for everybody, but parties, birthdays, culturally speaking, it's a large group. Everybody's having a drink. Everybody's gonna have, the rice, the beans, the fried this. So it adds on.
Yeah. So
and then, sorry, I wanted to add too, along with those things that can be modified, there's also factors that contribute to the higher risk as well. Hypercoagulability is more likely in the Black population. A sickle cell disease, these oddly shaped blood cells are, I mean, I don't know the actual percentage, but more likely in Black Americans in particular, right? And these are all contributing factors. So there's a lot, but there are things we can do about it. Like I said, it's hard to change our diet, though. That one I have found for people is the hardest thing to change, really.
So after this, we need to do another community chats to talk about how to have fun, because you're taking all the fun away from us.
I know. No fun allowed, and you won't have a
We are.
Also, Shelby, you said that there are people who have like little strokes that might go unnoticed, but then you might have a big one.
Right.
Do we have any idea, or you, Dr. Arian, after you have one of those little strokes, is that giving you like a heads up that, okay, maybe in a month or 3 or 6 months, you're going to have a major one?
So, so first let's define little stroke, okay?
Mhm.
Because Shelby had touched on it before that sometimes people are calling mini strokes when they're not. So to us, a stroke, regardless of size, is if your MRI or CAT scan is positive. Okay. So
And what
if
does that
that
mean? Sorry, what does that mean, the MRI being positive?
that means the stroke is seen on the image.
So the MRI is displaying an area that the blood cannot get to. There's an area of brain that is essentially dead at that point, and that's what you mean by a positive stroke.
Correct. So even if the patient has no symptoms, if it's on MRI or CAT scan, it's a stroke. Now, if you have symptoms that go away within 24 hours, that's a TIA. That's what most people call a mini stroke. We call it TIA because to us, a mini stroke is a stroke that didn't leave you with any problems. So that we need to differentiate. Now, a TIA, yes, if you have symptoms and they go away within 24 hours, TIA. The risk in 90 days can be between 4 and 9%, depending on your risk factors. We have a scoring system called the ABCD2. That tells us from 0 to 6 where the risk is. If we feel the risk is high, we keep you for the night and we'll do all our workup. If we feel the risk is low, we can do it outpatient. But the risk is between 4 to 9%. It's like a chest pain, but not a heart attack yet. So we want to be aggressive so it doesn't transform.
Right. Thank you. That is why I wanted to mention, because there's a lot of the community often, I hear it often when people come in that they'll say, well, I've had mini strokes in the past, and they're referring to these transient events or TIAs. Transient meaning these symptoms came and they went away totally on their own. They may have presented to the hospital or not, but there was no intervention required, right? And I want to explain a little bit about why that's happening and why that would lead to a true event. It's because whatever plaque or occlusion is there causing these symptoms at this point, it's not a true occlusion, right? So say this is the vessel and this is the clot, it's kind of waxing and waning with blood flow. And that's why these symptoms are coming and going and resolving on their own. Once that occlusion becomes large enough to truly occlude that area is when we're having a true ischemic event, a true stroke. So that's why having these events prior is what clues us into that something may be coming down the pike there. Does that make sense?
Yes. Now, how do you know that you're having a mini stroke, a TIA?
Same thing. The difference between a TIA and a stroke is the symptoms go away after 24 hours. That's a TIA. It's the same presentation. Shelby, I touched on be fast. So facial droop, one side is weak. You're not making sense when you talk or you're slurring. Vision loss, sudden dizziness with balance issues. Those are all warning signs. Call 911. Because you don't know until time has passed. We will do our workup to see, is it a TIA or a stroke? Because you don't want to waste that time that Shelby talked about. Because once that 4.5 hours is gone, we can't give you that special medicine, TPA, TNK, to break the stroke.
Yeah. So you don't want to really have to wait like, oh, let me see if it goes away in 24 hours.
Yeah, no, don't wait.
Yeah, please don't wait.
Yeah, please don't wait.
I think that's important to make that differentiation, right? Because I might just come saying, yeah, it might be a little one, and
and that is the most common thing we'll hear. Like patients will come 1 or 2 days later. Why didn't you come? I went to sleep. I thought it would go away. I didn't think it would be that serious. That is the number one. I thought it would go away, so I waited. But then by the time they come, there's nothing we can reverse at that point.
Oh, wow.
Yeah, we would rather you come and it be absolutely nothing than you to come 2 days later and be like, well, my left side's been numb for 2 days. Unfortunately, it's going to be numb forever because we can't do anything to fix it at this point.
Yeah.
So time is of the essence. Please don't wait.
Better safe than sorry.
Yeah. Absolutely.
Can the transient ischemic strokes or a stroke when in the beginning, let's say when it's first starting, can be confused with something else. I might think, oh, it might be this or that, but it's really a stroke.
Absolutely. There's a lot of mimics, if you will. The most common things that we'll see, and we're going to call them a stroke until it's proven otherwise, right? Because we want the workup done. We want to make sure that they're not having a stroke. However, migraine, Bell's palsy, vertigo are our three biggest mimics that we see on a constant basis. And again, we're still calling the code stroke. We're still doing the workup until it's proven otherwise. But those are really the three things, or like a hypertensive crisis.
Mm-hmm.
The other things that Shelby's right on that. Those are things that other things that can look like strokes are MS, low sugar, seizure sometimes after the seizure, complicated migraines.
Mm-hmm.
These can look like strokes. Some panic attacks, but not usually. They can look like it, but you won't know until you come in. High blood pressure can cause stroke-like symptoms. Medication side effects can cause stroke-like symptoms. It doesn't mean you definitely have it, but why? Better is safe than sorry.
Mm-hmm. Now, the problem that I see for our community is that, for example, I suffer from migraines, so I get a bad migraine, and now I'm going to be going to the ER every week. And of course, bills are going to start piling up and all of that for every visit to the ER. So is there something that can tell me I really need to go to the ER?
Be fast. What Shelby had said. If there's a change in balance, if there's a sudden change in vision, face, one side weak, your speech, you have time. Those are because those cover enough.
Yeah.
And typically the people, Dr. Arian actually specializes in headache and migraine, but the people that have migraines get migraines. They know what this looks like typically. However, if it is the first event, what signifies something different is that this is a okay, let me backtrack for a second. Migraines typically have what we call an aura prior to the migraine itself. Okay, those of you that suffer with, I won't go down the migraine route right now, but those of you that
another one on migraines, Dr. Eddie.
Those of you that know, right? So those of you that don't, we are talking about a sudden onset, worst catastrophic headache of your life. Debilitating headache is what we want you to come in for, if that's the case, right?
Like your brain is bursting.
Because it is.
Because it is.
That's why I use that word, Yeah.
We see that time and time and time again on nearly every patient that has ever come in with a hemorrhagic stroke. The words that they say when they get here, if they're able to communicate with us, is that it is the worst headache of their life.
Oh my gosh.
Yeah.
Wow.
And it's that sudden onset, right? There's no warning. There's no feeling beforehand.
Mm-hmm.
But it is almost in every case caused by an aneurysm rupture because of untreated prolonged hypertension or non-compliance with their meds.
So there is it's a super sudden. You're not gonna feel anything. It's just from 1 minute to the next. You're at your worst.
And that's also the stroke-like symptoms. It's a sudden, your face drops. It's a sudden, my arm got dead. It's a sudden, I can't see out of my. It's all the stroke-like symptoms are sudden. That's what makes them different. They're sudden.
And it sounds like it's one side only, right? Not like, oh, my head hurts. No, it's like one side, right?
Yes. What left arm is weak, left arm and leg, left face, arm and leg, left-sided numbness. My left face is down. And combinations. You'll see patients with combinations, like the whole left side is weak. Numb. And they can't talk. Yes, I did.
Yeah, it really just depends on the area of the brain that's affected. However, the symptoms are on one side, typically. I mean, depending on the area of the brain, it may be
Yeah.
your right arm and your left leg, but it's not both legs. It's not both arms. It's like that.
Mhm. Well, thank you so much. This is very helpful. I think you managed to scare me, but we probably do the same thing with the community, which is a good thing because
Yeah, we
now
don't
we're
want people
scared,
to
but
be
now we know what to do.
Yeah,
You
don't be
know, because
scared.
that's
Be
what we need
prepared.
to do. Exactly. It's like,
Mhm.
okay, now that I know what to do, if I feel something like that, at least, I know. Now, last question. You keep saying be fast, run to the hospital because we have to give you this medication that is going to reverse the stroke. So, what does this medication do? I don't need to know the name because it's
So, I'm sorry, was there another question?
What,
well,
say it again?
Did you have more to the question, or what was it?
no,
How
no,
does it
no, that's
work?
it. That's it. Like, what does this medication do that it looks like it's like a miracle medication right now?
So what it is, so the medicine's name is TPA or TNK. They're both the same style. What happens is within 4.5 hours, it's FDA approved. It is a medication. It's a one injection that we give if you qualify, because we go through a list of things if you qualify. But the medicine is a massive blood thinner. It's strong enough to break a clot. So if there's a clot that got to the brain, this will melt it. And then the blood goes to the brain, and then the damage is much less, if not corrected. And we've had patients who came in very badly, but once they got the medicine, the MRI did show a stroke, but they had no symptoms. They were almost 90%, maybe even 90 to 100% improved.
It's
So it has a
incredible.
very good outcome if you qualify. But after 4.5 hours, you cannot get it. So that's why the time makes a big difference because of how it works. So
And it's an injection in the brain.
no, you just get it in
I mean,
it'll be an IV. No, because that's actually a common question.
Yeah.
It'll be an IV, and it's just like getting IV fluids. It's just they'll just add it in and they just push it. It takes less
5
than
seconds.
what is it? 5 seconds. Yeah, it's a 5 second injection.
And I guess if my arm is already numb, but I'm not going to feel it. So,
That's true.
Yeah, the
That's
IV is
true.
already there. There's no needle. There's no needle.
oh gosh. Wow. That's amazing.
It is amazing.
It's really amazing. Yeah. And the fact that, here at the hospital, we can do all of that so fast. So now it's up to the person who's feeling the symptoms. So, I really want to encourage everyone out there who's watching this, please be fast, remember those symptoms, and just run over here and get treated by Dr. Arian and Shelby and the whole team, because they're going to really save you from some really bad consequences if you're not fast. Well, this was amazing. Thank you so much.
Thank
And
you.
thank you to our attendees for being here, for listening to us. We wish you the best health, and hopefully you never get a stroke or anybody, because I know it's something very, very difficult. And thank you, Shelby and Dr. Arian, for not only for the presentation, but for treating all those patients that you do every day. You really make a difference in their lives and the lives of their families who also suffer from the consequences of those strokes.
Thank
So
you.
I will see you next week in another community chat. Let me see what's gonna be next week. Maybe Dr. Arian wants to join us again. Debunking epilepsy myths. So we're gonna talk about epilepsy. So more about the brain. So thank you very much, everyone, and I will see you next Thursday.
Thank you.
Thank
Bye
you.
bye.